Hello! I will be presenting on obsessive compulsive disorder, OCD, 300.3 in the DSM-5, F42 in the ICD-10. Diagnostic criteria. To meet the diagnosis of OCD, you must have either obsessions or compulsions or both. Obsessions are considered recurrent thoughts, urges, or images that are intrusive and unwanted that cause distress in most individuals. The individual will try to get rid of these thoughts by attempting to ignore them or by performing a thought or action to neutralize them. The obsessions must occur at some time during the individual's disturbance. So examples would be recurrent thoughts, my hands are dirty, images, someone dying, urges, steer your car into another lane, distressing things that impede them in their daily life. Compulsions are repetitive behaviors or mental acts that individuals feel they must complete because of rules they must follow. The behaviors are done to prevent something from happening or to relieve distress, anxiety, but are they completely unconnected to the unwanted event or in excess. Washing hands because our germs is considered normal. Washing hands because 20 times a day is clearly in excess. B. The compulsions and or obsessions cause distress or impede the individual in one or several areas of life and or cause them significant distress. The symptoms cannot be linked to substance use or abuse. And D. The symptoms are not better explained by another mental disorder. I've listed some down here, but I won't get into those because I know that most of these are covered in today's class by others. So. Specifiers. The only specifier for OCD is insight. With fair or good insight means they understand the beliefs relating to their obsession/compulsion are not true or could possibly not be true. With poor insight, they think the beliefs relating to their obsession/compulsion are probably true, but maybe not true. With absent insight or delusional beliefs, they think the beliefs relating to their obsession/compulsion are absolutely true. Someone who washes their hands to prevent COVID, if they were unable to wash their hands at some point when a compulsion hit, they believed they may get COVID, they probably get COVID, or they have COVID, or are certainly going to get it. The only other specifier, because I forgot this one, is tic-related. The individual has a history of a current or past tic disorder. I won't get into specifically what these are in case someone else is covering them. But a good example of this would be Tourette's. Features and notes. So the mean onset age in America for being diagnosed with OCD is 19.5, but diagnosis can occur in children and adults, although it's unusual for the first one to be diagnosed after the age of 35. Patterns of symptoms are more stable in adult but more variable by children. This is due to different developmental ages and what is considered disturbing to that age group. So as children age, it'll get, what they consider disturbing is going to go bigger and bigger as they're exposed to more, but adults are pretty stable. OCD without treatment is a chronic condition with symptoms waxing, waning, but some adults do have episodes and very few have deteriorating OCD. 30% of people with OCD will have it for their entire lives. Common themes for compulsions, obsessions are cleaning, symmetry and order, so that'd be like counting or organizing things, taboo thoughts, and harm to self or others. It is common for people with OCD to avoid any person, place, or thing that may trigger their obsession or compulsion. OCD is largely seen across the globe with similar patterns in symptoms, outlook, and development. And suicidal thoughts occur in roughly half the OCD population, and attempts happen in around a quarter of the population. Comorbidity. Most people with OCD will have another diagnosis. 76% will have a lifetime anxiety disorder. 63% will have a depressive or bipolar disorder. Major depressive disorder has 41% alone. 12% will have a schizophrenic disorder, and 30% will have a tic disorder. Differential diagnosis. I've separated these into those that can also be comorbid as well. So anxiety disorders can be a differential, or they could be comorbid. Major depressive disorder could be differential or comorbid. Other obsessive compulsive disorders, eating disorders, tic disorders, which would also be comorbid, psychotic disorders, or obsessive compulsive personality disorder. Recommended EBPs. So there is the main recommended EBP. The first line treatment is exposure and response therapy. 76% of those who participated showed regained in 29 months after treatment. And ERP is one of the main components of CBT therapy. SSRIs as medication, used best in conjunction with therapy, as gains are limited when drug is taken. When you get off the drug, your whatever benefits you got from taking the drugs slowly starts to wean off. CBT, of course, just in general, and the main one again is a conjunction of ERPT, SSRI, and CBT. That is the recommended treatment from American Medical Association. Vignette. Sorry, my cat is screaming. Shh. My vignette. Marie is a 21-year-old college student who claims she doesn't do drugs and rarely drinks. Marie started having upsetting thoughts of harming children 2 months ago around her semester finals. Marie claims that one day she just started having thoughts like, I'm going to stab that child, or I'm going to push that child into the street, and would get images of the children injured after having the thoughts. Marie is very distressed by these thoughts, as she is an early education major and always loved being around children before these thoughts started to occur. Marie tried at first to ignore these thoughts, but when that did not work, she would start counting to 50. Marie knows it's not plausible or true, but is very worried that if she messes up her counting to 50, that she has to kill the child, or something else horrendous will happen. She says she doesn't know why she would have to, but in the moment she gets very concerned and worked up and is led to times where she gets very dizzy, has trouble breathing, and her heart starts pounding. After a few weeks of trying to ignore or suppress the thoughts, Marie stopped going out in public or watching or reading anything that may have children in it. Marie had to take a semester off school, but is too ashamed to tell anyone around her about the thoughts because they are so horrendous, and she worries others will judge her for it. At this point, Marie has not left her apartment in 3 weeks and orders foods/goods through a delivery service, but her savings are being drained. She also quit her job as a babysitter when the thoughts started. Marie is very distressed. She may have to drop out of school before her senior year because she will be a student intern at a local elementary school. So, diagnostic criteria, pulling out things that I put in my vignette. So, upsetting thoughts of harming children starting 2 months ago, would get images of the children injured after having the thoughts, and Marie is very distressed by these thoughts. All meet the criterion for obsessions. So A1 under obsessions would be reoccurrent thoughts, urges, or images that are intrusive and unwanted that cause distress in most individuals. So she is getting both the thoughts and the images. Marie tried at first to ignore these thoughts, but when that did not work, she would start counting to 50. So this is, again, the individual tries to get rid of these thoughts by attempting to ignore them or performing a thought or action to neutralize them. Marie stopped going out to public or watching or reading anything that may have children in it. The compulsions or obsessions cause distress or impede the individual in one or several areas of life and are causing them significant distress. She's also, while not part of the diagnostic criteria, again, it is very common for people with OCD to avoid any trigger for their OCD thoughts. Suggested EBT. So the frontline choice for OCD is, again, CBT with EBT, ERPT, sorry. And the American Medical Association's recommended treatment is ERPT and of the CBT with SSRI medication. So this is what I would recommend Marie do, a combination of ERPT, CBT, and SSRI medication, which she would have to follow up with her primary provider. The ERPT would allow her to gradually work through seeing triggers for her obsession in a controlled space where anxiety can be monitored and worked through therapeutically. ERPT is great because once she grows comfortable with it in the therapeutic setting, she can then take it home and slowly work on it in her own home setting. Whether she has family that can help her or whether she has to do it by herself, she can slowly start opening herself more and more. The SSRI would allow for continued stabilization after the ERPT ended and may help her when she becomes stressed and more likely to have issues with her obsession. Marie's thoughts started to occur around her finals, so they might be stress-based. The SSRI would take about 6 to 12 weeks to kick in, so in the meantime, the ERPT would help get her stabilized and with good coping skills and learning more about her triggers. And then the CBT in and of itself would help Marie work through her thoughts and the rules she created around them and work on the logical fallacies of them. And then these are my references. Of course, I have the DSM-5 and then selecting effective treatments. Thank you.